Good morning, friends. It's a pleasure to present to you my observations on tropical post-infectious arthritis. I wish I had something to disclose. Infectious diseases in tropics constitute a significant proportion of medical consults. It's been estimated that almost 5 million deaths occur annually because of tropical infectious diseases. Infections can involve any organ system in the body. The GI and respiratory system is most often involved. Musculoskeletal system can also get involved, like we see tropical pyomyositis because of staph infection, infective discitis because of brucellosis or tuberculosis. But today we are going to discuss post or para-infectious arthritis. Let's see this gentleman's story. He's a 24-year-old man who had fever for almost 1 month. After 5 days of fever, he developed polyarthritis involving ankle, knees, and wrist. And for the last 7 days, he has noticed red, tender nodules on his legs, suggestive of erythema nodosum. However, he denied any significant system involvement. On examination, he had erythema nodosum in both his shin. He had swelling and tenderness of the involved joint. The systemic examination, except revealing 2 centimeter hepatomegaly, was unremarkable. The investigations showed that he had an elevated acute phase reactant. His chest X-ray and ultrasound abdomen were normal. The erythema nodosum biopsy showed that it had septal paniculitis without vasculitis, and there were no granulomas seen. His autoantibody screen was negative, but the PPD test was positive with 25 millimeter induration with ulceration, suggesting tuberculosis is one of the diagnoses. The CT chest confirmed that he had bilateral patchy consolidation with small cavities, and bowel fluid confirmed a diagnosis of Mycobacterium tuberculosis. Thus, he had pulmonary tuberculosis with Ponce's disease. On treatment with antitubercular therapy, he had a remarkable improvement in his joint symptoms within a matter of 2 to 3 weeks. Ponce's disease can also present differently. Like in this lady, she's a bank employee in our campus who had swelling over both ankles for the last 15 days, and she had polyarthralgias for the last 7 days. She was initially seen by a nephrologist who found that she had no proteinuria. Then she went to an endocrinologist who thought she could have hypothyroidism, but however, the TSH was normal. When she came to us, she denied any history of fever, cough, weight loss, any subcutaneous nodules, or any other systemic complaints. The examination was unremarkable except the local examination, which showed brawny edema over the ankles, which was extending to the feet, which was tender, erythematous, and on deep palpation, he could find small subcutaneous nodules just above the ankle. He also had a highly positive PPD test. The ultrasound of the ankles showed tenosynovitis of the peroneal tendons, and the chest X-ray revealed bilateral hilar nodes. The HRCT, in addition to showing hilar nodes, also showed mediastinal lymphadenopathy. A transbronchial lymph node biopsy was done, which confirmed a diagnosis of pulmonary tuberculosis. Thus, this lady had nodal tuberculosis with Ponce's disease. The tuberculosis can affect musculoskeletal system by multiple ways, like direct infection of the joint or the synovium by tuberculosis. It could also be an immunological reaction to a TB, which is happening other part of the body, like we saw in the previous 2 patients, or rarely, the drugs which we use to treat tuberculosis, like pyrazinamide, can cause precipitation of gout. Ponce's disease was described more than a century ago, and the initial concept which Ponce had was of polyarthritis occurring in a setting of visceral tuberculosis, or in a person who had a family history of tuberculosis, or a person had joint tuberculosis at some other site. The exact pathogenic mechanism for Ponce's disease is still not clear. It could be a T-cell response to mycobacterial antigens, including the mycobacterial heat shock proteins, and there is some suggestion that genetic susceptibility may predispose individuals to develop Ponce's disease. In addition, we know that certain mycobacterial antigens are cross-reactive to the proteoglycans present in the cartilage. And finally, the immune complexes formed with the mycobacterial antigens can precipitate in the synovial capillaries and lead on to immune complex mediated arthritis. The clinical spectrum is varied, and this table shows a review of literature done a few years ago and a series from India. We see that there is no gender predilection, even though Ponson's initially described it as a polyarthritis, but it can present both as oligoarthritis as well as polyarthritis. The commonly involved joints, as was seen in our patients, is ankle, knee, and wrist. Erythema nodosum is seen in about 1/3 of individuals. The site of tuberculosis can be both pulmonary or extrapulmonary. MON2 positivity is seen in majority of patients. Based on their observation, Sharma and Pinto have suggested a preliminary diagnostic criteria for Ponson's disease, which has the essential criteria of inflammatory, non-deforming, non-erosive arthritis, the major criteria of occurrence of extra-articular tuberculosis, and a complete response to anti-tubercular therapy. Thus, this diagnosis can be made only in retrospect. The minor criteria are presence of hypersensitivity due to TB, like PPD positivity, or presence of erythema nodosum, tuberculosis, or follicular conjunctivitis. For TB, just to conclude that in tuberculosis, rheumatoid factor and anti-CCP can be seen in a significant proportion of patients. Thus, Ponson's disease may be difficult to differentiate from early rheumatoid arthritis. It can also simulate Lofgren syndrome. So we must do a PPD test in endemic areas to exclude TB. And if it is positive, a CT test should be done to look for lymph nodes as well as parenchymal lesions. In a small series of 18 patients presenting with Lofgren syndrome, 8 of them turned out to have tuberculosis. The garden variety tuberculous arthritis, which is because of direct infection, is usually monoarticular and can be erosive and responds very slowly to anti-tuberculosis. So it's not a very difficult to differentiate it from Ponson's disease. Moving on to another mycobacterial disease, that is leprosy, which is seen also in tropics. We have a story of this 51-year-old man who presented to us with short history of 2 weeks of swelling and pain in joints of hands and feet. He had no significant systemic features. On direct questioning, he informed us that he had paresthesias in hands and feet off and on for 2 years, but he hasn't bothered about that much. On examination, he had polyarthritis. He had extensive tenosynovitis in the wrist, as well as swollen feet syndrome. He had no skin lesions. There was a 50% loss of sensation on the dorsal as well as lateral aspect of right foot, suggesting neuropathy, and he had thickened common peroneal nerves. The investigation showed again elevated ESR and CRP, negative serology. The nerve conduction studies confirmed polyneuropathy. The slit skin smear for leprosy was negative. So we did a synovial biopsy, which showed only mononuclear infiltrate and no acid-fast bacilli. Finally, a nerve biopsy was done, which shows dense lymphomononuclear infiltrate both in the epineurium and in the nerve bundles. The AFB stain showed occasional Mycobacterium leprae, thus confirming a diagnosis of lepra reaction with pure neurotic leprosy. He was treated with multi-drug therapy with corticosteroids. However, the response was suboptimal. That is why thalidomide was added. And he had an excellent response to this therapy. Nigel is in the audience. We had long ago reported arthritis with pure neurotic leprosy. And if you see here, out of these 5 patients, 4 of them had symmetrical polyarthritis, while 1 of them presented only with tenosynovitis. It's a challenge to diagnose these patients because they don't have any skin lesions. But nerve biopsies can be diagnostic. So the arthritis and lepra reaction can precede or follow a reaction. It is usually acute in onset. The arthritis is severe, leading to disability, and tenosynovitis is commonly seen. Since it is acute in onset, mostly radiographs don't show any erosions. The synovial biopsy, as we saw, rarely shows Mycobacterium leprae, and the response to therapy is excellent. Leprosy reactions can present in another way also. This young patient presented to us with skin nodules for 20 days, which were erythematous, started in the upper limbs, and then progressed to the shin. He also had polyarthritis for the last 10 days involving the hands, ankles, and feet. He had excellent response to NSAIDs. He denied any systemic symptoms except that he had had mild COVID infections 10 months ago. But we didn't think that his symptomatology was related to COVID. On examination, he had multiple erythema nodosum lesions, both in the upper limbs as well as in the lower limbs. His both common peroneal and ulnar nerves were palpable, and he had tenderness in the MCPs, and the left ankle was actually swollen and tender. We did a skin biopsy from one of those nodules, which shows dense lymphoplasmacytic infiltrate in the dermis, especially around the appendages. On high power, we can see that these are like granulomas, which have foamy macrophages, and this further higher power shows that these are really foamy macrophages interspersed with lymphocytes. The weight fight stain showed multiple Mycobacterium leprae in the skin biopsy, thus confirming a diagnosis of erythema nodosum leprosum. So in our clinic, we had collated data on what we see as leprosy. Erythema nodosum leprosum is the most common manifestation. In the setting of pure neuritic leprosy, it can present as tenosynovitis, arthritis, or swollen hand and feet syndrome. Rarely, lepromatous leprosy can stimulate lupus, and you need to be careful. Residual neuropathy can present as claw hand or as a mimic of rheumatoid arthritis. Rarely, leprosy can lead to vasculitis, like a Lucio phenomena, but it's a very rare manifestation. It presents with small superficial ulcers. And obviously, leprosy involves the nerves, so the patients with long-standing leprosy can develop Charcot's arthropathy. How do you differentiate these ones? The lepra reaction, the swollen hand and feet syndrome, and tenosynovitis is usually an acute presentation with symmetrical and can be associated with polyarthritis. Most of the time, you cannot demonstrate Mycobacterium leprae. And all of these have good response to multi-drug therapy, along with anti-inflammatory therapy. While for chronic arthritis, which is because of direct infection of the synovium, the response to therapy is only moderate. And in Charcot arthropathy, because it's the end stage, there is no therapy except rehabilitation. This is the data from the multinational cohort of erythema nodosum leprosum, where they collected data on 292 subjects, and it clearly shows that skin nodules are the most common manifestations seen in the skin, and among the large joint arthritis is more common than the small joint arthritis. Can we predict development of erythema nodosum leprosum in a patient with leprosy? So this is data looking at antibodies to Mycobacterium leprae specific antigens, which are mostly phospholipids, even though patients who later develop reaction had higher antibody titers, but the discriminatory value was poor. So thus, there is nothing which can help us which patient is going to develop reaction later in life. The mechanism is basically a type 3 immune complex mediated pathogenesis because you have high titer antibodies which can activate complement, can cause activation of neutrophils, leading on to development of neutrophil extracellular traps and mediated inflammation. There is some role of Th17 cells also implicated in ENL reaction. So to conclude, in leprosy, when you have a patient presenting with polyarthritis in tropics or a person who has stayed in tropics for a long time, always ask for neuropathic symptom and palpate the nerves. If you have erythema nodosum in the upper limbs, the possibility of ENL is very strong. Palpate the nerves, take a good history. Swollen hand and feet syndrome has multiple etiologies, and leprosy is one of them. Moving gears to viruses. Viruses can affect joints and cause acute arthritis in many types of viral infections. However, we are concentrating on post-viral arthritis, and among them, chikungunya is one of the most important. And we have seen large epidemics occurring in the last 2 decades. This is a story of a staff nurse who works in our hospital who presented to us with polyarthritis of 3.5 months involving wrist, elbows, knees, and ankles. This was associated with swelling. When it started, she had high-grade fever, which lasted for about 5 to 7 days, and she had an erythematous rash. At that time, she was in Kerala, which was a hotbed for an epidemic of chikungunya virus. At that time, when she was tested, she was found to be IgM antibody positive. Because of the disability, she could not come back to work, and she had come back now. She had no significant relief with non-steroidal anti-inflammatory drugs. At the time of presentation to us, she had 8 swollen joints and 10 tender joints. Thus, we made a diagnosis of chronic chikungunya arthritis. These are the other manifestations which can be seen in chikungunya arthritis, and I thank Sapan for providing me these slides. So you can have extensive tenosynovitis, you can have symmetrical polyarthritis. On MRI, you can see arthritis, you can see tenosynovitis. Erosions are very rarely seen. If you do a bone scan, you can rarely see enthesitis, and sometimes you can see a swollen hand and feet syndrome. The exact mechanism of chronic arthritis is not known. For acute arthritis, we know that it is because of virus replication, both in the muscle and in the synovial cells. But for chronic arthritis, it is either a low-grade viral infection persistence, or it is because of development of autoimmunity, which is because of cross-reactive antigens between the host as well as the virus. This is a recent data which has looked at persistence of joint symptom 3 years after the chikungunya infection, and at 20 months, almost 1/4 of patients had joint symptoms. But at 40 months, almost half of them had abated and half still had persistent symptom. Looking at people who had persistent joint symptoms as compared to who did not have joint symptoms, it was seen that there was no difference in the swollen joint count, but it was a tender joint count which was different. And obviously, there was affection of the normal activities of daily living. This is a meta-analysis which looked at the prevalence of chronic arthritis, which is a little older, and it was seen that around 40% of patients develop chronic arthritis which lasts for more than 3 months. There is a divide. In India, the persistence arthritis is seen only in 1/4 of patients, while in French Polynesian Island, it is seen in about half of the patient. So this could be related to the genetic basis. What are the various joints involved? In acute arthritis, it's been seen that in India, it's more often the upper limb joint involved, while in other countries, more often the lower limb joints involved. While in chronic arthritis, it is usually the joints which are involved in rheumatoid arthritis, like the hand, feet, and the knees, which are often involved. How do you treat chikungunya chronic arthritis? People have tried everything, including most EMARDs, hydroxychloroquine, methotrexate, combination of methotrexate and hydroxychloroquine, and other DMARDs. All of them have shown a minor benefit. The effect size is not very large. The pain relief can be achieved with non-steroidal anti-inflammatory drugs and low-dose corticosteroids. This is a study which was done by Sapan, which enrolled a significant proportion of patients, and they showed a very good ACR 20 and ACR 50 response. Because the disease is non-erosive, we need to temper our therapies and use therapies which are safe. A recent studies done in animals have shown that abatacept, which is a co-stimulatory blockade, can reduce the severity of arthritis if used in conjunction with antiviral therapy, and fingolimab, which is basically a lymphocyte recirculation inhibitor, can also decrease the arthritis. But these are therapies still in the realm of research. So think of chronic chikungunya arthritis. It can absolutely mimic rheumatoid arthritis, or take a history of travel or rash in the endemic area. Tenosynovitis is seen in a significant proportion of patients and is seen more often than what we see in rheumatoid arthritis. The arthritis is usually non-erosive, and it's also been seen that it is seen much more in older individuals, people who have comorbidities, and people who had high viral load and severe disease at the time of acute illness. Just a word about filarial arthritis. The filaria can cause both mono as well as polyarthritis. In the mono or oligoarthritis, microfilaria are usually not present in the synovial fluid, and it is thought that this is an inflammatory reaction to the worm, which is maybe in the subcutaneous tissue in the near vicinity. Rarely you can have a chylous arthritis, which is because of rupture of the lymphatics. It responds beautifully to the antifilarial therapy. While the polyarthritis is a immune complex mediated arthritis and is seen less often with lymphatic filariasis and more often with onchocercosis and loea disease. There's an interesting case report which is recently published, where a patient had Ewing sarcoma in the femur, and he also had a joint swelling. When the joint was aspirated, you could see microfilaria in the joint. So microfilaria sometimes can be a surprise. So just to conclude, tuberculous tropical post-infectious arthritis is an important entity. Arthritis with tropical infections can occur because of direct involvement, because of it could be a post-infectious or a para-infectious manifestation like ENL in leprosy or Ponson's disease in tuberculosis. It can be a reaction to infection in the vicinity like what you see in filarial arthritis. Think of Ponson's disease when a patient presents with arthritis along with erythema nodosa or a Lofren's-like picture. Think of ENL when you have a patient with polyarthritis and is complaining of neuropathic symptoms. Examine the nerves to see if they are tender and thickened. Post-chikungunya arthritis absolutely simulates rheumatoid arthritis. A good history and a serology may help you think of it. All these, fortunately, are non-erosive and have good response to therapy. Thank you.